students and our residents.
Randy, can you see the hand raise function there?
I can. Let's see. We got Dr. Nettleman.
Okay, we'll let you run that then.
Hello. I just had a question for Anna on her pharmacogenomic testing. I wasn't clear on what percentage of people got a drug for which the pharmacogenomics would indicate they should not have, and whether or not there ought to be some type of thing that you consider it almost a drug allergy in some cases, so you actually prohibit it from happening, because it's problematic, as you know. Things pop up all the time on your screens.
Right. Well, hi, everyone. I'm Anna, and I did the presentation on the physician responses. And so we didn't analyze that specifically, but what we were gathering is if they have an adverse metabolism genotype or phenotype, and that's what we collected. So all of these patients should have had an adverse genotype, so they shouldn't be on the medication. That's why it was popping up. And so when a lot of them, and I didn't, because this is just newly collected data, so we haven't analyzed it down to the individual points. But our next step is going to be is how many did actually just continue the medication? Is it one of those more, not placebo, but is it that it's working for them, so they're just going to keep going? Maybe, but I mean, I know too, I'm not a provider yet, but all those pop-ups, it can be a lot. So I think that's kind of, did that kind of answer your question, Dr. Nettleman?
All right. Thanks. Dr. Kumar?
Thanks, Randall. I have a question for Mohammed and one question for Hilal. So let me start with Mohammed. Mohammed, you said your findings are that the patients with hepatitis admitted to the academic center had increased infection rate compared to the non-academic center. But is it true of the same for other diagnoses, of any diagnosis patients admitted to the hospitals at academic center have more infections?
So we did this study as there was already a study done regarding increased complications with alcoholic hepatitis patient in the NIH's database. So we only focused on the rate of infections for now in the alcoholic hepatitis patients, and that was the data only gathered during this study. And we can look into other ones, but we didn't gather those information during the study.
To my recollection, academic centers do have a higher infection rate compared to non-academic centers in all diagnoses. So
that's generally correct, and they usually say, I think it's because of severity of illness, among other
Correct.
things.
Yes, and we also were thinking there would be less mortality, or there might be some differences in the use of resources, but that mortality and resources were similar. And so we were doing a correlation between this, and also there were more complications in those patients to the academic centers. I was limited by the title, so I did not include that part of the study in this presentation.
Thanks, Mohammed. Excellent presentation.
Thank you.
The second question is for Hilal. May I proceed, Randall?
Yeah, go ahead.
Hilal, that was a great presentation. My question for you is, in Fabry's disease, you mentioned that in this particular case you presented, you looked for coronary artery disease, but the patient presented with recurrent SVTs. Did you look into pre-excitation syndrome with accessory pathways? Is there any correlation between accessory pathways in patients with Fabry's? You're muted.
Hello, you're muted.
Okay, can you hear me?
Yep.
Correct.
Thank you, Dr. Kumar, for the question. So I'm just aware of this patient's EKG, which didn't reveal any pre-excitation, but she didn't underwent any electrophysiological study. And her SVT was in the pattern of AV and NRT. So an accessory pathway was not suspected in this patient. Regarding your question, is there any association between the accessory pathways or Fabry disease, like I'm not aware of. Like the main pathophysiology in Fabry disease is that it involves the myocytes, and the resultant pro-inflammatory deposition leads to myocyte death, and this causes fibrosis. So this usually presents a form of conduction abnormalities, or this causes an area which is isolated where you have some dead myocytes. So this may cause some re-entries, and you can see this like in the form of atrial flutter or VTs, VTECs. But I'm not aware of any association like any accessory pathways or Fabry disease. But that's one thing maybe I should look into further.
Yeah, Hilal, I couldn't. Your audio was kind of breaking up in between, so I couldn't hear all that you said. But I had to point out that a person with accessory pathways can have normal EKGs most of the time. Intermittently, they can show the true shortened PR interval. So a normal EKG doesn't exclude an accessory pathway.
Yes, but her presentation was doesn't necessarily exclude, you're right. But her, like I just said, like it's SVT, but the form of the SVT was AVNRT, not the AVRT.
Okay. Great.
And so they didn't go ahead and do any electrophysiological study.
Thank you. Dr. Davies, you have a question?
I do, thanks. All wonderful presentations. I appreciate everyone's work. And I have a couple of questions. One, maybe I'll just go to Luke first, who talked about the carpal tunnel. And you're getting in, Luke, to one of my areas of interest, and that's sort of practice management. But it's easy to mix up reimbursement and cost. And I think, looking at it from the societal point of view, we want to provide care at the lowest possible cost, right? That's a different thing than sort of gaming insurance companies to get the highest possible reimbursement. I guess I'm interested, Luke, in what the reaction was from the people you were working with about that issue of reimbursement versus cost. Were they willing to do the lower cost care even if the reimbursement hadn't caught up?
That's a great question. And I think that'll continue to be a discussion as the research progresses. Initially, as you can imagine, being a business, they're a little hesitant when you tell them that we're going to do a lower cost procedure and get less for it. But it is promising that other people have done similar studies, and then they subsequently present this to the insurance companies and say, there's a win-win opportunity for everyone here. And then they can kind of negotiate and say, we're trying to decrease cost. Would you kind of treat this like you treat the OR? So I think it'll take a while to kind of get there, but there is the possibility of not only decreasing the cost, but also getting insurance on board to also help the patients.
Thank you. Good answer. The second question I have, if I may, is for Anna on the pharmacogenetics testing. And again, you're hitting on one of my sort of passions about alert fatigue and alerts. And I wonder, Anna, if you interviewed any of the providers involved who did not respond to the alert. Did you get a sense just from the talk, from how people reacted to it, on whether it was alert fatigue, knowledge deficit, which it would be for me, I think, or some other factor, just, and I know it wasn't in your data, but just from what your sense was of the process?
Yeah, that's a great question. So interestingly enough, I didn't interview a physician about this, but on my LIC rotations, I was with two different physicians that this came up with as I was speaking with the patient. And so I was in their chart and we were just kind of talking. I was writing the note and it popped up. And so one of my physicians knew exactly what was going on, and had researched, just kind of knew the background of, what that meant and what these results meant, and explained it to the patient. And then the other physician that I was with, they immediately X'd out of him. They're like, I have no idea what that was, and, kept going. And so, I mean, they're both great physicians and care for their patients, but I do think it's a combination of the alert fatigue and then just some of the knowledge deficit, because I saw both of those. Unfortunately, because I was doing this research, I was like, wait, I know how to do this. Like, I can actually explain this. And so I was able to help those patients for that. But I think it's a combination of those two.
Thank you. And then one final comment from me would just be, sometimes it's how the alert is worded too.
Right.
I mean, if the knowledge deficit is common, then wording your alert to help close the gap there might be a better system design, than the prior. So,
For sure. We definitely need to do something about it. So.
oh yeah, great. Thank you very much. Thank you,
you.
Randall.
Just,
Those are my questions.
All right, thanks, Dr. Davies. And I'd actually just kind of add to the, just on for one of those pharmacogenetics one is with the Plavix after the cath lab. It does have a bigger description. It's a BPA that just looks different than other BPAs. And I find that one pretty helpful if it pops up as well, because of how it's worded and how it looks. And it has that description about maybe what to consider with that from that standpoint. So Dr. Nettleman, you had a question?
I was just going to do a follow-up with Luke on the costs associated with the carpal tunnel. The other point, and I certainly agree that the net cost to society is a very key perspective. You almost always have to fix your perspective, figure out what your perspective is. But I was wondering if you also looked at out-of-pocket costs for the patient, because they're the ones probably least able to bear a differential that's significant.
For a self-pay?
No, even co-pays. Medicare pays what, 65%, maybe less. A lot of insurances will pay much less for an outpatient procedure. And so the differential might be something.
Yeah, that's a great question. That's something that we haven't looked into yet, but I'm sure that would be an excellent follow-up, just to kind of see, once we kind of get one aspect of it, what would be the follow-up as far as how much patients have to actually pay themselves. Great question.
All right, great. Any other questions? I do not see any other hands raised here.
Well, if there's time, I have one more.
Oh, yeah, we got time, Dr. Davies.
And I'm kind of less confident about this question, so I saved it for last. So for Lauren, who talked about the nitric oxide NOS, which I'm not very familiar with, Lauren, I confess.
Okay.
I was wondering, your hypothesis was that, I think, that if vasodilatation happens, that it's could lead to strokes, I think, or have an impact on strokes, I think is what you were saying. So could you explain that a little further? And then the question I have is the vasodilatation effect different if a patient has underlying ASCVD than if they have normal arteries?
So we did not look into that aspect at all. We only looked at just diabetes. So our hypothesis was that in diabetes, their arteries do not vasodilate as well as someone who does not have diabetes. And then we found that the CB2 receptor actually seems to rescue that. It seems to help people with diabetes, and that their arterioles, after taking it, start to dilate more readily. Does that answer your question? I'm sorry, yes, we have not looked into the coronary artery disease at all.
Okay, yes, that I guess that reminds me, and it helps to answer the question. Thank you.
Yep.
I guess I think at the very end, your conclusion was this could interact with people with cerebral vascular disease. Is that right?
I believe so. I don't have my poster pulled up right now, but I'm pretty sure.
So are you saying that it could reduce the incidence of stroke?
Correct. Yes. Yes.
Gotcha. All right. That'd be interesting to pursue.
It's on the ballot.
I just voted yesterday, and all of a sudden I was like, oh boy, now I'm presenting on this tomorrow.
Very good. Thank you.
Randy, it looks like we have one from Priscilla in chat.
Okay, I missed that one. Sorry, Priscilla.
Just got put in there.
Okay. Priscilla, did you want to ask your question, or do you need me?
Yeah, I couldn't figure out how to raise my hand, so
Okay.
the chat. This one is for Luke Hurley, and I'm wondering if you were looking at any difference in patient outcomes. If I were a patient, I'd be interested not only in the cost, but whether there's any difference in improvement in symptoms or any increase in infection rate in the clinic procedure versus the OR procedure.
That's a great question, and something that has actually surprised me throughout this whole research project is that there have been several studies indicating that post-infection or post-procedure infection rates are actually much lower in the clinic compared to the operating room. And that's actually with much less sterilization techniques. So it takes a while to get used to seeing that and kind of rationalizing that in your head. And then to kind of point to your other question, as far as patient outcomes, that's kind of a follow-up study that we're gonna do after this, is looking at how patients perceived their procedure and kind of looking at satisfaction rates. And so far, not at Sanford specifically, but other studies, other locations that have done similar studies with carpal tunnels have also found that patient satisfaction has been significantly higher in the clinic.
Great. We have a couple other questions yet. Dr. Kumar, another question?
Priscilla already asked the question which I was going to ask, but just to add to that is that for Luke, it's not actually a question, is that the payment which will eventually come from the insurers, because the insurers will eventually win this argument. If the outcome is the same, if the cost is less, the precedence for this is the sleep labs, the home monitoring of sleep studies. Mike is very aware of this one. The neurologists and pulmonologists fought hard, saying that the sleep lab is the best way to study the sleep apnea, not the home study. But eventually the home study has been proven and much more cost effective, and the insurance companies won. So it is just a question of time.
And there's a question from John.
Yes, so my question is for Anna. Do you, and forgive me if this question already came up and you've answered this, do you anticipate pharmacogenomics drug recommendations to become part of standard care practices? And if so, do you anticipate some sort of malpractice potential avenues to come out of that as well?
Wow, John, I really don't know the answer for the malpractice part, but I just think personally, I think it's something that maybe we can pay a little bit more attention to. And I do agree, we talked about this before, that we maybe can come up with a better way for these BPAs, because they are kind of annoying, and I mean, they're important, but it is hard to keep up with all of them. And so I think it's become more of a standard of care. I'm not sure how much more it will, but maybe some of the providers that are on here, because I'm sure they've seen the evolution and the changes of these BPAs throughout the years. Any thoughts from anyone else?
It's really tricky, the threshold of importance where to set a BPA. And, you know, it's true that there's lots and lots of BPAs out there that maybe aren't that essential, certainly contribute to provider fatigue. And so I think what's crucial is that when you do put a BPA through and it actually lands in the electronic medical record, that it's clear and it has very clear and significant clinical utility. Otherwise, you know, like Anna, you put very well, I mean, it's just going to be something that gets blown to the wayside. So we just have to be very judicious in our use of BPAs, and that's really not happening yet because there isn't really a known or appropriate threshold set, and you know, it's pretty subjective too. So it's difficult, but it's a huge issue.
Yeah,
Yeah.
and I'd like to speak up too. So this is Mike Davies again. In the VA, you know, in my past experience, I was part of the group that created electronic clinical reminders early on. And it was fascinating because when there was just a few of them and they were aligned with what the performance measures were, they were extremely effective. I mean, it was dramatic differences. As time went on, though, these kind of got out of control. And there's different groups, you know, started putting in reminders for things they thought were important. But as I think Eric just said, the clinicians really blew them off because either they didn't know or they were overwhelmed. So I've come to believe that it's really important to have a committee that has significant input by practicing clinicians, you know, who are affected by this every day, who can help bring some sanity to the current world of electronic reminders, because they can certainly help, but they can also hinder.
And this is Rob Allison in Peer. So, and I would agree as well. I mean, trying to figure out how to put this in my practice is the hard thing. I don't order a lot of pharmacogenetics testing. And so as that becomes either kind of standard therapy or you come into a clinic and you get tested, I think it's more valuable. But if you don't order it, you don't know about it, and then you just don't put it as part of your workflow. Looks like we have Sue Bornstein in here, coming here at 2:30. It's 2:24. Any more final questions? We might take a 5-minute break in between here to stretch your legs, and everyone could stay on their video and not move anything, and then we could get Sue set up. But any final questions for our students and residents? Fantastic job. Randy, any final words?
No, I actually just going to make a quick comment about what Mike was saying. We do actually have physician committees that determine what goes into a BPA, what BPAs we're going to do. And those actually then go on to another committee of a group of physicians that then determine if that is actually appropriate. So we have a couple of committees where those things get approved at, just so you guys are aware of that. And that's why when you're out in practice, it's great to get involved in whatever healthcare system you're in, get involved in those committees and participating in that as well. Just to echo what Rob said, really outstanding presentations today. Thank you to all of our students and residents as well. So congratulations. And we'll take that 5-minute break here then, Rob, and go from there.
Just everyone just, you know, either put your video off if you want to run around. Sue will get ready. We'll get her talked to, and everyone back here at 2:30.